So to start, let's get to the basics here. Why is nutrition so important? And to answer this question, I think we need to think a little bit more broadly. This study was published about a decade ago and does a pretty good job at illustrating just how important nutrition is. It was a comprehensive look at the state of health in the United States, and it's a little dated in 2010, but published in JAMA. And the focus was on overall poor health in the United States, but what I took away from it was that there were 17 leading risk factors in the United States for poor health and related deaths. And at the top are dietary risks, and they defined it as diets that were low in fruits and vegetables, high in sodium, high in processed meats, trans fats. That was the leading cause of death above smoking, high blood pressure, diabetes, all these things. So it's within this landscape that we reside here, that our patients reside here, the high sugar, convenient foods, highly processed things that our patients are living in. And so, we can't really think that they're immune to the effects of diet on health either. And in recent years, dietary habits may have even gotten worse. So this was a survey done early in the pandemic of roughly 3,900 US adults asked about their consumption of different types of foods, unhealthy versus healthy, sugary drinks, and so forth. And they reported consuming a much higher quantitation of unhealthy foods and sugary drinks than pre-pandemic. And I think we can all probably relate to unhealthy food choices when we're not, we're kind of stressed and anxious, or maybe having that extra glass of wine. No doubt our food choices have likely changed even in the last 100 days, given all the anxiety that we're experiencing right now. So all of these things can also impact an intake. But specifically to Thal, there are additional reasons why nutrition is so important. Until recently, our primary focus has been, on optimizing transfusion and chelation therapy, and rightly so. That really needed to be where our focus was. But now we have kind of a better understanding of the role that diet plays in overall health. We know that replete nutritional status is integral to optimizing growth and pubertal development in our young patients with thalassemia. That vitamin D, zinc, and K, and as well as protein, are really important for maximizing bone health and immune function. Zinc has also been shown to decrease the risk of diabetes, while vitamin D is related to cardiovascular disease and even kidney stones in our patients. Moreover, it's been shown in non-Thal populations that the food we eat can really affect our mood, how we feel about the day-to-day, how fatigued we are, how much pain we feel is actually impacted by the foods that we eat and how our body responds to stress. So, it wouldn't be a stretch to believe that if we had the funding, the resources, and the interest from the scientific community focused on nutrition and some of these quality of life, mood relationships in thalassemia, that we'd see very similar kinds of things. But I'll also be the first to say that nutrition, health, and dietary management doesn't function in a vacuum. It's synergistic with clinical care, and that is, nutrition will not only and should not only take the place of optimal transfusion and chelation care, but just enhance the things that you are already doing as clinicians. But what's unique about nutrition is that it really lies heavily on the patient and what they chose to eat, of course, or what they choose not to eat. And that gives the patient the unique sense of control. When it comes to diet, the patient has the power to make those choices. But what complicates all of this is that there's so much information out there that is available to the patient, from friends and family suggestions to online media reports of new cleansing diets. And some of it can be quite misleading and downright dangerous. And because you're the provider and kind of the first point of contact for many of these patients, your ability to provide accurate information to patients is really critical, and providing you that resource is valuable. So that said, there's a number of different things that can lead to nutritional deficiencies, particularly to our patients with thalassemia. So I'd like to highlight some of those. And the most fundamental reason for nutritional deficiency is related to inadequate dietary intake. This may occur because patients have poor access to healthy food, kind of the basics. So they might be residing in communities with food deserts. Anemia itself can lead to fatigue and disinterest in food. Anorexia, or the loss of appetite, can also result in decreased intake, which could be related to medications or even nutritional deficiencies. that result in altered intake and smell. Interestingly, my favorite nutrient, which is zinc, zinc deficiency it can also lead to an alteration in appetite and taste and smell, which can reduce intake. You are very familiar with chelator medications, and that can lead to GI distress and cramping, and patients that are on pain medications. So we know a number of our patients experience pain on a regular basis. Those pain medications can lead to constipations, which also can lead to reduction in appetite and intake. Individuals that have various different food allergies or intolerances, such as celiac disease, which I think goes unnoticed in many patients, or more commonly lactose intolerance, can lead to a reduction in foods that are really high in vitamin D and calcium. And then food restrictions based on culture could also limit intake in certain food groups. Inactivity, which I think is often overlooked, reduces our appetite. When we're more active, we have a better appetite and we're actually consuming more food. And as I mentioned before, that stress and anxiety and depression can lead to changes, not only in reductions, but also changes in our food choices. But the point that I think I want to make that's almost the most important is this thing about nutrient density. So that's what I'm going to address here and speak specifically to. And what do I mean about nutrient density? It's consuming a diet that has a high amount of essential nutrients per calorie. One of the easiest ways to add density or variety to the diet is to add color, which seems very simple, and it's a gimmick that we use often in the nutrition field, is to eat around the rainbow. Because all the foods that have different colors have lots of different vitamins and phytochemicals. When I'm talking about eating around the rainbow, I'm not talking about tricks and colored goldfish, though. I'm talking about different fruits and vegetables that have different natural food colors, not artificial colors. Another trick to enhancing density and variety in the diet is to consume mostly natural foods versus packaged foods. So encouraging our patients to decrease the packaging in their grocery cart and to switch to whole foods as much as possible, to cook at home rather than eating out, to bring leftovers for transfusion days rather than having packaged foods, and to limit foods with added sugars and high fructose corn syrup. Not only are those very low nutritional value, but as I'll point out later, they also, high fructose corn syrup has been related to an increase in absorption of iron that might be problematic, especially for our non-transfusion dependent patients. So to illustrate a few examples and maybe make you hungry for lunch here, of meals that are packed with nutrients compared to sort of poor nutrient dense diets. So for breakfast, say, a patient might have pancakes and syrup, which, yes, it's very filling and seemingly a lot of calories, but it doesn't have many nutrients. So that could be replaced with, say, oatmeals, cranberries, blueberries, coconut flakes, and almond milk, which is much higher in antioxidants, fiber, zinc, and calcium. And then replacing sort of a lunch of chicken nuggets and French fries with things that more fruits and vegetables, and different sources of protein that are lean and high amounts of monounsaturated fatty acids. And then say for dinner, rather than having just plain white pasta with a marinara sauce, that actually having whole wheat pasta increases your amount of fiber as well as protein with other types of vegetables and cheeses that could add some density to the diet. So you can see it's kind of white food versus colored food, but having lots of fruits and vegetables also enhances the nutritional value of a nutrient-dense diet. So apart from inadequate intake of nutrients, patients may have nutritional deficiencies because of poor absorption. There's surprisingly few studies that are focused directly on the gut in thalassemia, but what we do know is that in mouse models that iron overload induces an increase in gut permeability, thereby leading to some alterations in absorption. And of course, oral chelator medications that you know so well can bind and reduce the absorption of other trace elements, namely zinc and copper, if there's less iron for them to bind to in the gastrointestinal tract. There may also be an increase in utilization and excretion of certain nutrients, whether that be due to renal dysfunction, iron overload, or increased oxidative stress, which can catabolize your antioxidants such as vitamin C, E, zinc, and selenium. Oral chelators can also increase the excretion of other divalent cations like zinc and copper, as I mentioned already. And there may be an upregulation of metallothionein in the liver in response to iron overload, which will sequester many of the nutrients that metallothionein binds to, such as zinc and copper, making them functionally unavailable. And then finally, the hypermetabolic state of thalassemia, especially pre-transfusion, related to the increase in red blood cell red blood cell turnover and tachycardia, can lead to increased requirements of folate and zinc, and the cardiac output then that could also lead to an increase in energy requirement. So all of these things can lead to overall an increase in nutritional deficiencies in the populations that you work with on a daily basis. So in light of this, which nutrients have we observed to be most deficient? So I'll start with the macronutrients. And when I talk about macronutrients, I'm talking about energy, protein, carbohydrates, and fats. And in general, most patients that you probably see on a regular basis are maintaining a relatively healthy weight, and their caloric needs are then matched with their dietary intake. And this is kind of what we've seen by the data. The few studies that have looked comprehensively at dietary intake in patients with thalassemia. Our study that was published a number of years ago using the Thalassemia Clinical Research Network, or TCRN, and we looked at young children, adolescents, and adults. And then the Egyptian study that was published in 2020, looking primarily at children with thalassemia. We found that actually the percent of energy expenditure was actually pretty consistent with what the requirement was, meaning that if you actually look at total calories from a dietary assessment and then calculate what energy expenditure is, the percentage of calories to expenditure was actually was higher. So meaning that they were meeting the needs of their of the requirements. That was not necessarily the case in the Egyptian study, where the total caloric intake was lower than the control group, and that was also leading to some challenges in growth in that population. But in our population here in the States, that consumption of total calories would seem to be adequate. In both studies, the amount of protein that was being consumed was pretty adequate. So the recommendation for protein intake is about 10 to 20% of total calories from protein. In both of these studies, the average intake was about 15% of protein, which is pretty consistent in the US diet, that we all consume a fairly high amount of protein. In this study, the thal patients were consuming about 1 gram per kilogram. The recommendation is a little bit less than that, so they were getting likely adequate sources of protein. But what I want to illustrate here was the total amount of calories that the patients were taking in was relatively low to meet their requirements. So the adults were only taking in 2,000 calories. The adolescents were taking about 1,500 calories, which is relatively low. So you can imagine trying to get all the nutrients that you need in the amounts that you need is really challenging in a 2,000 calorie diet. And so if you're consuming a really low nutrient dense diet, you're not getting all those nutrients. So that's kind of a key take-home point there. Drilling down just a bit more, in that same TCRN study, we looked more specifically at food groups and how the average consumption of whole grains, fruits, and vegetables relate to the US recommendations for dietary intake. So this is for healthy intake, for the recommendations for healthy individuals without disease. And we saw that the food groups that were lowest were whole grains and dairy. The recommendations for whole grain intake is about 3 servings today, 3 to 4 servings a day, and most of our patients were taking in less than 1 serving a day. The same with dairy intake, that they were taking in 1 to 2 servings a day, and the recommendation is 3 servings of dairy. Now, it could be that patients are limiting whole grains in the diet because of iron fortification of whole grains here in the United States, or it could be just dietary preference, and whole grain foods are sometimes hard to consider or to put into the diet. Dairy intake may be low because of lactose intolerant, and I'm certainly not one to just promote dairy, but dairy is a really essential, or not essential, is a really sort of efficient way to get calcium and vitamin D and protein in the diet. And when dairy's intake is limited, it's really hard to get the amount of calcium that you need in the diet. But why do we care about whole grains specifically? It's really because they're rich sources of fiber, vitamin E, so antioxidants, B6, and protein. They also have a significant amount of magnesium. So they're really a rich source of protein and antioxidants compared to more of the refined flours. Fiber is critical to gut health, and it's also helpful for weight maintenance and glucose control for our patients who are at risk for developing diabetes. So a higher whole grain diet can be beneficial for glucose control. So moving on to our micronutrients, a little bit of a review here from maybe your med school days. You might recall that there's 30 essential vitamins and minerals naturally found in our food that can't be synthesized by our bodies. You may know that vitamin comes from the term vital amines. Because many of the first discovered vitamins had amino groups, so vital amines. Anyways, each are unique metabolism and functions. They're typically divided up into 4 different categories: your water soluble, your fat soluble, your trace elements, and macrominerals. So your water soluble is your vitamin C, folate, thiamine, niacin, riboflavin, and so forth. The fat solubles are your A, D, E, and K. The trace elements that we're typically most concerned about are zinc and calcium, but also manganese falls into that category, and selenium, another antioxidant, and your macrominerals. The prevalence of nutritional deficiency really varies quite widely in the literature, depending on where the studies were done and the population of interest, and whether or not they were chelated, if they're transfusion dependent, and so forth. So we tried to summarize this in a publication a few years ago, looking at the most commonly reported nutritional deficiencies in thalassemia. And we identified 97 separate studies that looked at nutritional deficiencies in various different nutrients, and identified roughly about 9 different nutrients that were commonly reported to be deficient. And in this graph with these histograms, the nutrient is on the bottom by fat soluble, water soluble, or mineral. And the number of studies for that nutrient are in parentheses. So there were 28 different studies reporting vitamin D deficiencies, 22 different studies reporting zinc deficiencies. And the studies that I want to highlight today are those focused on the ones that really had the highest amount of deficiency. So vitamin D and zinc, roughly half of the patients reported in all the studies combined turned out to be deficient in those particular nutrients. And then I'd like to address vitamin C as well, because there's some relationship with chelator efficiency that I think is important to discuss. So I'd like to start with just a little bit about vitamin D. I think this is something that you're all probably very familiar with. As you know, it's really crucial for calcium absorption, of course, for bone remodeling, but also cardiac function, which I think sometimes goes unnoticed. The food sources, the natural food sources for vitamin D are really quite limited. So fatty fishes and egg yolks, unless you're living in a country like the United States that fortifies foods, such as our dairies are fortified. You, as you know, can also synthesize vitamin D from the skin through UV exposure. So deficiency is quite common. Though the ramifications of deficiency sometimes go unnoticed. In children with severe vitamin D deficiency results in vitamin D deficiency rickets. In adults, osteomalacia. But in adolescents, there's a number of reports showing muscle fatigue, and then it has been related to cardiomyopathy. Specifically to our patients with thalassemia, there's quite a number of reports about vitamin D deficiencies. These 2 reports, also a little bit dated, but I think highlight the prevalence of deficiency and insufficiency in these stacked histograms. So this was the study by Vogiazzi from our TCRN group, showing the high prevalence of insufficiency in the dark blue bars, and then frank deficiency at this point defined as less than 11 nanograms per mil. But across the board, not only in our transfusion-dependent patients, but also in the non-transfusion-dependent patients. And then on the right, the stacked histogram, just from our center here in California, showing the percent of subjects both in the transfusion-dependent on the left column, and then our alpha thal or hemoglobin H's and H constant springs also had a really high prevalence of deficiency, and we defined it at that point as less than 20 nanograms per mil. So vitamin D deficiency and insufficiency is rather common. Now, toxicity is not super common, but can present given it's a fat-soluble vitamin. And typically it presents with hypercalcemia or renal stones in most patients. So specific to thalassemia, vitamin D deficiency can affect the heart muscle, causing left ventricular dysfunction associated with cardiac iron uptake. This was an Italian study published in 2023. It was a cross-sectional study that I think highlights this relationship between low vitamin D levels and an increased prevalence of cardiac T2 star, less than 20. So as vitamin D drops, patients are actually increasing the uptake of iron into the heart. On the other side of things, hypercalciuria is common in our transfusion-dependent patients. And this was also from that TCRN study years ago, where we found the strong relationship between hypercalciuria and patients that had vitamin D, 25-OH, so the storage form of vitamin D, above 30 nanograms per mil. But it was only in the transfusion-dependent patients. We didn't see it in the non-transfusion-dependent. So something to be aware of, that as we start supplementing with higher doses, that hypercalciuria may be prevalent, and something to be concerned and to be monitoring, especially in our patients with low bone mass. So what are the recommendations for vitamin D? To monitor regularly. We know that vitamin D has this seasonal variability, right? Because we synthesize vitamin D in the skin. So when we're exposed to more sun, higher levels in the summer than in the winter. So if you have an ability to monitor more frequently, that's optimal. If you have the capability of doing the total vitamin 25-hydroxy D2 and D3, that's optimal. And looking for a range between 20 and 30 nanograms per mil to optimize not only bone health, but decrease the effects on cardiac function. The maintenance dose is somewhere between 1,000 to 2,000. At our center, we typically have a maintenance dose of about 2,000. And to recommend to take along with vitamin K. So vitamin K really works synergistically with vitamin D to sort of shuttle calcium into the bones. It activates the proteins that help deposit calcium into the bones. So preventing it from collecting in the arteries, with sometimes that's the case with higher dose calcium and vitamin D supplementation. For those who are less adherent to daily dosing, because it's a fat-soluble vitamin, you can get away with giving it less frequently. So you can give 50,000 IUs at the time of transfusion. And so if they're transfused every 3 weeks, that translates to about 2,700 IUs per day. For those who are more deficient, we recommend higher doses, or 50,000 IUs every week for 8 weeks, and then reassess. So zinc is involved in well over 300 different enzymes and cofactors in the body. It's really important for optimal immune function, growth, pubertal development, insulin metabolism, and bone mineral accrual. There are a variety of different sources of zinc that mainly are sources that have high amounts of protein, and zinc kind of cohabitates with iron. So for your non-transfusion dependent patients that may be limiting iron in the diet, they may also be limiting zinc. The best food source of zinc is actually oysters, and Atlantic oysters are a very rich source of zinc. For anyone who likes oysters, there's 90 milligrams of zinc in a 3-ounce serving of Atlantic oysters. So just putting a plug there for those, for whatever is on the bottom of the Atlantic Ocean, I don't know. And that, so to put in context, the RDA for zinc is about 8 to 11 milligrams per day. Deficiency can result in increased infections, diarrhea, and poor growth. So it's really something to be monitoring, especially for your patients who might not be growing adequately. Delayed puberty, glucose intolerance. So a lot of these things that we see as comorbidities in thalassemia also we see with zinc deficiency. Alopecia, hair loss, and poor bone metabolism. Toxicity is not super common, but yet if you're giving a high dose, especially zinc sulfate, it can result in some nausea, stomach cramping, and vomiting. And a high dose for a longer period of time, months, can result in copper deficiency. So whenever you're giving doses above 25 milligrams a day, you should also be monitoring copper. For our patients with thalassemia, we see roughly 25 to 35% of our patients here in the United States typically have zinc deficiency. Sometimes it's going unnoticed. You see it more common in some of our international studies. It's very common in many of the Iranian studies, not only in thal patients, but also in the general population, and perhaps that's related to the food supply. So specific to thalassemia, as I mentioned, zinc deficiency is quite common, particularly with chelator toxicity and iron overload. It's been associated with poor growth, altered glucose metabolism, and this is sort of an illustration of some work we did years ago, looking at the effect of low zinc versus normal zinc on the response to an oral glucose tolerance test. And so the patients that had low zinc here on the dashed lines had an inadequate insulin response to the oral glucose tolerance test, which led to an elevation in blood glucose up at 120 minutes. So meaning that they weren't able to elicit the appropriate insulin response that resulted in hyperglycemia. We also know that zinc is related to low bone mass, and the study that we did years ago looking at zinc supplementation, it was a 25 milligram zinc dose for 18 months, found that it actually moderately improved bone density in this young group of patients with thalassemia. They were 10 to 30 years of age. So there is some potential enhancements, especially for your patients who may have low bone mass and are at risk for zinc deficiency. So zinc supplementation could improve many different aspects of the thal comorbidity state. The recommendation is to monitor annually and replace if deficient. And we define deficiency as less than 70 micrograms per deciliter. The supplementation would be roughly 25 milligrams a day, or if you can only find the 50 milligram dose, to give that every 2 days, and that should be sufficient. So vitamin C functions as an important antioxidant, and it's critical for collagen synthesis, but it also plays a valuable role in iron metabolism. It's essential for non-heme iron absorption and stimulates ferritin synthesis. But it's also required to mobilize iron from tissues to remove liver iron stores. Therefore, vitamin C deficiency has been associated with ineffective chelation in some of our patients. As you know, that there's the food sources of vitamin C are pretty obvious. It's usually citrus, orange juice, peppers, strawberries, even potatoes are relatively good sources of vitamin C. But we found a fairly high prevalence of vitamin C deficiency, circulating vitamin C, here in the United States. Our study in 2018 found about 20% of patients. Susan Klasser's study from 2009, which were the iron overloaded patients, found about 65% of patients were low in vitamin C, and the Egyptian group found all of their patients actually were deficient in vitamin C. Deficiency can result in scurvy-like symptoms, bleeding gums and bruising, poor wound healing, and so forth. There actually are a few case studies of scurvy in heavily iron overloaded transfusion-dependent patients that have severe vitamin C deficiency. So that has been reported. Toxicity is uncommon given it's a water-soluble vitamin, but for patients who are taking really high doses of vitamin C, you can develop a rebound scurvy if you stop sort of cold turkey. So it's recommended both not to take high doses in our patients and also not to stop. And I'll talk about that in 1 second here. But specific to thalassemia, we've noticed that circulating vitamin C decreases with increasing liver iron concentration. So meaning that, that oxidative stress from liver, from iron overload is catabolizing the antioxidant, leading to reductions in circulating vitamin C. And this was a report we had a number of years ago looking at the steep decline in vitamin C as liver iron increases, particularly above 15 milligrams per gram dry weight. So the Egyptian group also looked at the possibility of supplementation of vitamin C. And this was a study of 180 transfusion-dependent patients divided into 3 equal groups, so 60 per group. They gave 100 milligrams of vitamin C a day for a year and found that liver iron concentration decreased significantly in those on deferoxamine and deferoxyrox, not in the deferoprone group. But so it's been suggested that any patient that has an unsatisfactory response to chelation should be tested for vitamin C deficiency. And then the recommendation is that if you are deficient, and we define deficiency as less than 0.4 milligrams per deciliter, that consider supplementation, but only with adequate chelation. So nothing more than 100 milligrams a day, and only if you can ensure that there's adequate adherence to chelation, so that you know that you're not increasing NTBI without an adequate chelator response. So you're probably quite familiar with the literature about very old literature. Some of these studies were done back in the 70s, looking at how tea inhibits iron absorption and has been incorporated, I think, in many of our patients, especially our non-transfusion dependent patients, and the effect that phenolic compounds have on inhibiting the absorption of iron. So these phenolic compounds are present in not only tea, but also coffee, cocoa, and even red wine. There was a nice study that was just done in 2020 that were a number of non-transfusion dependent patients and found a significant drop in liver iron concentration when they were drinking 3 cups of green tea after meals every day for 12 months. So really definitely works quite efficiently for non-heme iron or reducing non-heme iron absorption in our non-transfusion dependent patients. The recommendation really is it can be black tea with or without milk. Milk doesn't have any effect. Black tea has more tannins than many of the herbal teas do. Caffeine doesn't have any effect, so it doesn't matter if it's decaf tea or decaf coffee. On the other side, I think I want to make you aware that there's some in vitro studies that were done a little while ago that suggest that high fructose corn syrup can actually enhance bioavailability of iron. So another reason to try to limit the amount of additional sugars in the diet or high fructose corn syrup, because it could be adding to some of the problems that our patients are experiencing. So the last general comment to make here is about not about nutrients per se, but some about the botanicals, because I think that a number of our patients are experimenting with botanicals and may be coming to you with some of these questions. So the first and probably the most studied of many of the botanicals is curcumin, and it's the active phenolic compound in turmeric. It was discovered over 200 years ago, and it may have both antioxidant as well as anti-inflammatory properties and benefits to our patients. The most commonly studied dose is between 500 to 1,000 milligrams per day, which equates to about 1 to 2 tablespoons of turmeric per day, which is shown to be somewhat beneficial in certain population of patients. But it's uncertain if there's any similar benefits that are the case if you're just using a daily consumption of turmeric in food preparation. So wheatgrass comes from newly sprouted leaves of the wheat plant. It's prepared in a variety of different forms, from juices to tablets. It has been explored to attempt to reduce the transfusion requirement. But the challenge with many of these studies is that there aren't any randomized control trials, and the assurance of what is on the label of the product is given that it's not monitored here in the United States, it's really inconsistent with the product and what the patient's getting. So I would say at this point we don't really have adequate information or confidence in understanding what wheatgrass is doing. L-carnitine is also an antioxidant, may improve cardiac function, particularly for patients with advanced heart disease and carnitine deficiency. The doses that have been used in a few studies that have been reported are about 50 milligrams per kilogram per day. There is caution about individuals with hypothyroidism or those that have a comorbid seizure disorder. So to use it really closely with the patient and not just going without medical advice here. And the last one is silymarin, that is potentially hepatoprotective, may be useful in patients that have some liver complications. It's derived from milk thistle, and it functions as a free radical scavenger. The dosing that's often used is fairly high. It's 140 milligrams 3 times a day. So there again would need to be considering that with medical advice prior to using it. So then getting to the specifics of how do you know when a patient is deficient, or more importantly, how do you know who might be at risk for deficiency? So how to accurately assess that. So a comprehensive nutritional assessment is really key to this. At minimal, the anthropometrics would be needed, looking at height and weight at a minimum, routinely measured, of course, in your children and adolescents that you're already doing. But height loss should also be looked at in your adults, given that might be a sign of vertebral compression, and so would definitely be an indication for doing a lateral spine scan for those patients that are seeing significant height loss. Monitoring body composition is also beneficial, especially for your patients who are at risk for developing diabetes, particularly visceral adipose tissue, which now can be assessed by DEXA, the whole body DEXA. So that's something that's available to you. Then, of course, biochemical assessments. Oops, sorry. Biochemical assessments is also important, looking at the laboratory analysis of serum and in some cases urine. It's recommended to do kind of a nutrition panel annually, looking at least vitamin D and zinc, but also the antioxidants, which is valuable. And then a clinical review of signs and of nutritional deficiencies. Many of them are vague, but might be an indication of underlying nutritional deficiencies, such as alopecia, which could be resulting from chelator toxicity, but also could be a zinc deficiency. And then, of course, looking more specifically to a dietary assessment to understand the root of some of the nutritional deficiencies that may be present. The recommended monitoring frequency for many of these things are optimally annually as a nutrition panel. However, with vitamin D, maybe more frequently so that you can get that seasonal variability with some of your patients until you have an understanding of how often they're out in the sun, you know how much it drops in the winter. For vitamin C, you might want to do it more frequently if there's an unsatisfactory response to chelation to understand what their vitamin C is looking like. And then, of course, for your fructosamine and things, these would be done in your patients who are diabetic and your OGTTs starting at 10 years of age. So these are all in the TDT-TIF guidelines as well as in this nutrition text that we have. So what can be done about it? If you discover a nutritional deficiency, what would you do? So I think first and foremost, though, I am a nutritionist, and I always talk about trying to get most of your nutrients from diet alone. For many of our patients, that's going to be really challenging given their consumption of total amount of calories is really low. So we do recommend a vitamin mineral supplement without iron. So I'm not advocating these particular brands per se, but these particular brands do have a good source of all the different fat and water soluble vitamins, as well as many of the minerals, and don't have iron. So Centrum Silver or a one a day without iron. The recommendations for these particular nutrients for supplementation, so these are things I've already addressed. So if you do define a deficiency in any of these nutrients, then supplementation of 25 milligrams a day of zinc would be adequate. Vitamin D at roughly 2,000 IUs a day for most patients, along with vitamin K2. And then for those who are less adherent to daily dosing, doing 50,000 IUs at time of transfusion. Again, with vitamin C, we really caution the supplementation unless the patient does have adequate chelation on board. I want to highlight when to bring in a nutritionist, or when a nutritionist can be quite helpful to you as a clinical team. I think that there's a lot of instances for which their assessment of a personalized dietary strategy could be quite beneficial, particularly in your young patients that are picky eaters, for patients understanding how to read nutrition labels, how to look for those added sugars, how to read how much fiber is in a whole grain food, and so forth. Identifying foods that are high in iron for those non-transfusion dependent patients. Again, I think you're probably well aware that that's not really a concern for our transfusion dependent patients who are adequately chelated because they're getting so much iron from transfusion alone. But then strategies also about how to manage gastrointestinal stress from oral chelator medications, or how to increase the density of the diet. And then specifically for your diabetic patients, identifying low glycemic index foods and specializing in, for your patients who might have allergies or intolerances that or are concerned about what they're hearing on the internet, and could be a real resource to you for many of those patients. So I do think we have a couple minutes here. So I just want to walk through a brief, almost like a hypothetical case study that might bring home some of these points and pull them back together here. This is a case study of a 7-year-old with thal major, or transfusion-dependent thalassemia. It's ethnically Chinese, but was adopted 3 years ago, at 3 years of age. Does not reside closely to a comprehensive care center. Transfused every 3 weeks, is receiving both Jade Nu as well as Desferol, roughly 3 to 4 times a week. Seems that chelation is relatively good. The hemoglobin runs roughly 9 to 10 pre-transfusion. The ferritin runs in the 3,000s. Okay, so this is the sort of clinical picture of this young boy. So we'd start with getting some anthropometrics. So we see that his height currently is at the 20th percentile. His annualized growth velocity has improved, and his height percentile has actually been roughly at about the 20th percentile for the last 2 years. Now, the challenge, given that he's adopted, we can't look at his genetic potential for growth in the parents that you're working with. But given that he seems to be finding his growth percentile, that seems to be where what's adequate for him. However, his current weight at the 5th and his BMI is somewhat concerning, given that it's so low. He's currently still prepubertal. So I think the follow-up here would be really to monitor weight and BMI closely. and looking at more nutrient-dense foods that could enhance his diet. And then, given that he's also on Desferal and JADE-NU, high doses of chelation, to consider looking at sitting height and monitoring that and the growth velocity of sitting height as well as overall stature to make sure that you're not having any effects on truncal growth. So a quick dietary assessment revealed that he is actually vegan, that he's a fairly picky eater. He has a limited variety of diet. His parents primarily use a cast iron skillet when they cook. They're very health conscious. They make mostly everything homemade. And so you want to get a detailed dietary assessment. And the things that we're really concerned about here is vegan diets can be challenging to get both B12, because that's only from animal sources, protein, zinc, calcium, and vitamin D, because you're not having any dairy in the diet. So those can be a challenge and something to be considerate of and suggesting alternative plant sources for calcium. The use of the cast iron skillet is really not a concern in these patients, given that he's already chelated. So even though he'd be getting more iron in the diet from the use of this and cooking, I would say that's not really a concern for this young man. But to recommend a vitamin mineral supplement without iron. Now, for many strict vegans, often they refrain from wanting to supplement on top of their diet because they're anxious about adding B12 from an animal source in the supplement. But you could use the biochemical assessment to help illustrate to the parents that the child might need additional supplementation. So from your biochemical assessment, you found out that his 25-hydroxyvitamin D is actually relatively low. It was drawn in the spring, so that might be partly related to it, but that's something that would need to be repeated after supplementation. His zinc level is also slightly low. It's less than 70, at 65 nanograms per mil. His copper and vitamin C appears to be within normal limits right now, but his B12 is also low. So follow-up here would be to supplement with vitamin D, to supplement with zinc at 25 milligrams a day, and then to consider a multivitamin supplement that definitely has B12. And those daily vitamins, the Centrum Silver and so forth, usually have B12 at roughly about 6 micrograms, and that's would be adequate for replacement likely for this patient. So that's just sort of a quick, sort of illustration of some things that you could be highlighting in reviewing the nutritional challenges of a young patient that you might see at your clinic. So then just to summarize, replete nutritional status is really integral to optimal health and quality of life in our patients. And I really behoove you to utilize the local registered dietitian experience at your center. I'm sure you have quite a few that are quite experienced and may be very interested in working with you if they understood a little bit more about the challenges of working with patients with THAL and could really add to your clinical team if you don't have one already on your comprehensive clinical care team. To focus on a well-balanced nutrient-dense diet for all of your patients and consider a supplementation without iron, and then adding vitamin D and zinc primarily, but other nutrients where they're deficient, vitamin C. I didn't talk about folate much today, but folate often is something to be also aware of as well. And then all of this is really synergistic with current clinical care. So continuing to optimize transfusion and chelation strategies and assessment of all the other challenges and comorbidities that you experience on a regular basis. So with that, I'll just end by just highlighting the fact that this lecture is supported by HRSA and the grant from HRSA. And of course, all that I presented here is not their views, but mine. And I think I'll stop there.
Great. Ellen, thank you so much. We appreciate that. It was a tremendous presentation, as always. And I just want to see if we have any questions from anyone. You can either raise your hand or put a question in the box, whatever is your preferred method of communicating. But if there are any questions for Ellen?
Craig, hi, it's Sujit. I have a couple of questions and a comment at the end. Ellen, that was a really terrific talk, as always, highlighting things that we really don't pay enough attention to, I think. My questions are, you showed really good data on THAL patient intake compared with normal recommended daily allowances. what do thal patients actually need more of? I mean, where do they stand in terms, shouldn't their daily requirements be higher? For example, calories, for instance, given that they're chronically anemic, particularly NTD patients, do they need more calories than the recommended daily allowance just because they're kind of hyper catabolic?
Right.
Similarly, and I want to ask you specifically about folate supplementation. You didn't talk too much about it, but if they have a normal diet, do TDT patients really need folate? Um, and then finally, I just want to comment, I'm really glad you brought it up in terms of the vitamin C with chelation, especially in the highly iron overloaded patients. I worry that, if they're highly iron overloaded because they haven't been very compliant, then, if that non-compliance continues and they take the vitamin C, then you're actually putting them at higher risk because it mobilizes the iron out of stores, and then you can increase that NTD, the NTBI, and cause problems. So I'm really glad you brought that up because it's really something that we should make sure that we remember.
Exactly. And I'll speak to that. I think you hit the nail on the head there. That's exactly the patient that we want to avoid supplementation with, but potentially could be really beneficial, but you need to make sure that they're adherent to the condition before you do. So very good point. And hopefully, and I appreciate you stressing that so that is understood. With regard to the requirements versus needs, exactly right. I mean, so we were in that study years ago, we were relating it to the dietary requirements for healthy individuals in the United States, right? And so you would expect that our patients would likely have both increased, I mean, that's what I talked about, increased nutrient requirements for various different needs, especially our antioxidants. In terms of total caloric needs, it's an interesting point. There was a study done many years ago in Israel that looked at total energy requirement pre and post transfusion. And that was using indirect calorimetry, so looking at actual needs using indirect calorimetry, and they found that actually post transfusion that they were meeting the needs. That there wasn't an increased need, but it actually dropped as hemoglobin dropped. So once your hemoglobin got below, I want to say it was like 7 to 8 or something, then actually the requirement for total calories increased. So I think that there might be a variability with the transfusion cycle, and when you actually really drop low into your low levels of hemoglobin, that there might be increased requirements. But you can tell that if a patient is maintaining their weight, then probably what they're taking in, is what they need in terms of calories. That doesn't mean what they're taking in is what they need for nutrients, right?
Mm-hmm.
So that's the difference there.
Right.
So caloric need might not be much higher, but nutrient need may be, and that's the nutrient density piece. So that's a good point. And then folate. So we had a conversation about this at TIFF. They really do promote doing a folate supplementation, and there's only been a couple studies looking at folate in thal. I think for transfusion-dependent patients, it's unlikely that it's needed, but for those patients that maybe have really poor diets, not a lot of fruits and vegetables in the diet, then you could consider supplementation. And I think it's 1 milligram or whatever.
1 milligram a day. Yeah,
exactly.
Thank you.
Yeah, great questions. Thank you.
Any further questions? Anyone else have anything they'd like to ask or comment?
Well, if nobody has a question, can I ask another one?
Of course.
All right. So just in terms of, the mineral deficiencies, is there a difference between the chelators in terms of their binding efficiency for, say, zinc or magnesium or copper? So should we be more concerned if they're on one chelator versus another? Is there a sort of rank order as to, what's more likely to, what are they more likely to be deficient first versus next versus next versus next?
Excellent question, and I can't give you a super straight answer on that. But early on, we thought that the chelator that had the most challenges in terms of our trace elements was deferriprone. And that everybody who went on L1 was given 50 milligrams of zinc because of some early studies that suggested about 10 to 13% of patients, I want to say, develop zinc deficiency when they were on deferriprone. So that there's that literature, but when you look across the board at all the studies that have looked at chelators and zinc excretion, and I'm just talking about zinc here because most of them didn't do all the different trace elements, so we're kind of using zinc as a moderator for some of the other trace elements, the other divalent cations, that it really depended on whether or not you had patients that had diabetes in the study, because diabetes increases the excretion of many trace elements. Their actual iron load, so how iron overloaded they were at the time, and iron overload also sequesters many of our trace elements, and so that sort of decreases the circulating amount of these trace elements. So it's hard to just look at the chelator effect. And then for the dosing of chelator, the adherence to the chelator, and then what the level of NTBI or iron loading was at the time. So I would say that really, if you look at it in its entirety, I feel like none of the chelators, I mean, to me, it would think that the oral chelators would have more of effect than your sub-Q chelators. But I would say the literature doesn't really play that out. I think it really depends on the dosing, what the other comorbidities are there, and the adherence and so forth. So I think the better way is just adequately chelate, like you're going to anyway, and then just monitor for some of the trace elements. Yeah.
Thank you. We do have a question in the chat. Do you find yourself recommending calcium supplements? Is there any preference, such as carbonate versus citrate, or is absorption comparable? And this is assuming low dietary intake.
Right. Great question. And yeah, so as you're alluding to already, the preference is to get calcium primarily from the diet. So we find that it's less associated with nephrolithiasis or kidney stones if you're getting calcium directly from the diet versus supplementation. But that's not always the case. For our young man who's a vegan, coming from a vegan household, it's challenging. And so you may revert to supplementation. In the case of supplementation, so our recommendations here in the United States are really high doses of calcium. So for our kids between 9 and 18 years of age, the recommendation is 1,300 milligrams of calcium a day. That's a lot of calcium to get from a supplement alone. You probably don't need that much. We have a really strong dairy lobby, so that's partly what's going on there. But also, if your vitamin D is adequate, then you don't need quite as much calcium in the diet. So you probably need, closer to 800 to 1,000, which is the UK recommendations. And they're looking at the same data as we are here in the United States. So that said, the type of calcium, it really doesn't matter. The two important things are not taking more than 500 milligrams at a time, because you can't absorb more than that in one sitting. So giving a 1,000 to 1,200 milligram calcium supplement or taking all that at one time, you're going to actually decrease the absorption of that supplement. So it's better to actually divide up the dose. And then the type of supplement depends on your ability to absorb it with or without food. So citrate and citrate malate can be absorbed on an empty stomach, whereas oxalate needs to be absorbed with food. So it's kind of just dependent upon when the patient is going to be taking their calcium supplement, if they're taking it with breakfast or at dinner and so forth, or if they're going to be taking it, at night before they go to bed or something. So.
Thank you. All right. Are there any other questions? If not, I will say thank you, Ellen, so much. This was tremendously informative and very valuable. And as always, we thank you for sharing your expertise with us. And thank you, everyone that was able to be on today. We appreciate your joining us. And we will be posting this on our YouTube page probably within about a week. Okay, so thank you all.
Great.
And
thank you.
Have
Great talk, Ellen. Great talk.
Thank you, Ellen.
Everyone, appreciate it.
Take care.